Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Today I'll talk about the underlying disease, activity, and derivative of organ damage and SLE. As we know, the key burden of SLE development of organ damage, if the disease lifted and controlled, and underlying disease activity can lead to irreversible organ damage, mainly in skin and musculoskeletal, and more fatal organ like kidney, pulmonary, and cardiovascular. The leading cause or sequences of organ damage in SLE because of persistent disease activity and drug-related effect, especially glucocorticoids, that can lead to further damage and decrease quality of life, mood disorder, and decreased work productivity that lead to early mortality. The persistent positivity of antibodies that can appear before diagnosis of SLE and before the onset of clinical diagnosis, and that can lead to more burden to the disease, to the SLE patients. Although the control of SLE and disease activity has been improved, still the outcome remains suboptimal. Even we can see that throughout the years, the disease activity decreased, but still we can see burden, or still we can see more disease or more organ damage. The probability remaining free disease activity in the first 5 years, almost 83% of the patient will have related to glucocorticoids disease or disease flare, despite of a standard therapy. 6 in 10 patients of SLE patient experience the disease flare. 61% of the patient have accumulative risk disease flare in the first 5 years of diagnosis, and 42% of them, they have acute organ damage if they have SLE disease activity more than 1 year. And these all may be related to glucocorticoids disease, uses or the disease activity itself. 34% of the patient have increased death every additional point in disease activity. This was in the pooled hazard ratio and meta-analysis of 10 studies reporting risk that the patient have, if they have 1 unit increase in the disease, in the select disease activity, they have risk almost. They have those patients have early organ damage and has significant lower rate survival and 10 years of follow-up. The organ damage in SLE more likely to develop in the first 3 years post-diagnosis, and this will increase in the first 3 years by 119, and this may be decreased in the further years, and more than 18 years, the risk increase is 239. And this is maybe occur because of the disease activity and with glucocorticoids use. The organ damage, accumulative rapid in early stages of disease that result both in disease activity, flares, and persistent of disease activity is not slowly organ damage. The glucocorticoid use also can be important source of irreversible organ damage. This is what we shown in this study over 12 months, and the disease follow-up was almost 27.4 months. The glucocorticoid exposure also associated with organ damage occurred independent to the disease activity. Multivariable survival analysis examined the independent association between glucocorticoid use and damage occurred that may be related to ocular damage, musculoskeletal, and cardiovascular. And still this can occur despite the patient have no clinical or surgical disease activity, and the hazard ratio was 1.14. Most organ damage can be attributed to glucocorticoids in the short term as well as over time. There is independent glucocorticoid therapy organ damage like renal, pulmonary, gastrointestinal, cutaneous, pulmonary, and gastrointestinal and malignancy. And the possible related to glucocorticoids, cardiovascular, peripheral vascular disease, neuropsychiatric, and diabetes. The definite related is musculoskeletal and ocular tissue. The number of new disease, new SLE disease activity increase according to the duration of the disease. In the first year, there is 85% of the organ damage, and this is possibly to the definitely to the glucocorticoid use, and mainly to the organ that we mentioned. And almost more than 15 years, 80% of them, they have organ damage, possible or definitely related to glucocorticoids over 15 years of using medication. Even low dose steroid can cause adverse event, and the dose of 2.5 milligram, they may cause hyperglycemia, and osteoporosis can be caused by 5 milligram per day and throughout 6 months, and even cardiovascular diseases occur in 7.5 per day. Risk of infection also from 5 to 7.5 milligram per day, and to the more burden complication, which is a vascular necrosis, that may be happened in more than 30 milligram per day. Despite the time and dependency, this complication can be happened. The effect of glucocorticoids in organ damage now better recognized, and minimal glucocorticoids exposure have been the key priority, and that's what happened in the recommendation throughout years. The last recommendation in EULAR in 2019 was recommending glucocorticoid should be minimal as 7.5 milligram per day, and the withdrawn possibly, and the new recommendation in 2023, they decreased the dose to 5 milligram per day. The standard therapy alone cannot be enough to control disease activity and flare. That the disease activity, it happened, as we said before, the diagnosis of SLE. The autoantibodies happened almost more than by 1.2 year before the diagnosis. Multiple flare can happen, and disease activity. This organ damage accumulate over the SLE till occurring of the organ damage. This can be increase the comorbidities and worsen the disease prognosis, and higher use of glucocorticoids that associated with severe disease and accelerate the organ damage can cause poor health-related quality of life with SLE compared to the general population, and higher mortality overall that leads partly by organ damage occurring. That's why the recommendation they considered to use lower steroid maintenance target of less than 5 milligram per day and fully withdrawn if it's possible. The steroid uses can only be bridging therapy, and long-term exposure to steroid, they present major risk to the patients. And this is for non-SLE or non-renal SLE. The lower dose of steroid for long-term use and earlier short of biological treatment and SLE. So as we have to decrease the doses for 5 milligram per day, and the initiation of immunosuppressant now as early as possible to avoid the long-term exposure to steroid. It's not mandatory to initiate the conventional immunosuppressant. Introducing biological therapy now, like Bellista, to consider adding Bellista to the patient who is not responding to hydroxychloroquine plus steroid to reduce the dose of steroid to less than 5 milligram per day. Bellista have shown to control disease activity and reduce flare and halting the damage of acrine and facilitate the reduction of the dose of steroid. And the EULAR recommendation, now the change in the EULAR recommendation, after starting corticosteroid and steroid as a short course, if needed, we can start Bellista, belimumab and anifrolumab as a second line of mild disease and moderate, first line in moderate and severe disease to target remission and low disease activity with the presence of hydroxychloroquine and low-dose steroid. The lupus nephritis guideline in EULAR 2023, they use the lower dose of steroid as a maintenance dose, less than 5 milligram per day, with withdrawal if possible, and early combination therapy, either Bellista or calcineurin inhibitor, and should be considered as a part of initial therapy. We can combine the Bellista with low-dose cyclophosphamide or MMF, or calcineurin inhibitor with MMF, and consider this should be considered for all patients with active proliferative lupus nephritis, and regardless of the classification of their disease of the lupus nephritis. The treatment should be continued at least for 3 years to consider renal response, complete renal response. The patient with MMF and Bellista or calcineurin inhibitor should be continued for 3 years, and the patient on cyclophosphamide with Bellista should be changed to MMF or azathioprine with Bellista. And this is the 2023 recommendation for EULAR. They put the belimumab as a first line, either with low-dose cyclophosphamide or with MMF. As an alternative, we can use MMF as a azathioprine with belimumab. And this should be continued to target therapy 3 months and 6 months and 12 to 24 months. The target is the protein in the urine should be the reduction 25 in the first 3 months and 50% in the 6 months, and from 12 to 24 the less than 500 to 700 milligram per day. With the GFR should be reserved at 10%. So there is some highlight of overarching principle of the recommendation in SLE patient. The SLE disease activity should be assessed at each visit, if possible, and organ damage should be evaluated at least annually. The choice of a treatment for patient depends on the patient characteristic, the type of severity of the organ damage, the risk of progressive organ damage, and the treatment-related harm, among the other factors. The early SLE diagnosis and prompt treatment aiming to remission or low disease activity to prevent the flares and organ damage and improve prognosis and enhance quality of the life. So the Bellista, it's the first biological therapy approved for SLE and lupus nephritis as a targeted to the underlying disease. The use of Bellista was, the approval of Bellista was, started in 2011 for the first biological therapy approved for SLE. Throughout the years, it was continued to then approved for pediatric SLE as a first biological therapy for pediatric age more than 5, and then it was the first biological therapy approved for lupus nephritis in 2021. There are over 150,000 of patients they are using, or they used to be treated with Bellista over worldwide. So the moving from broad targeted approach to treatment of SLE from traditional therapies, the broad immunosuppressive mechanism, like the patient who was in the corticosteroid, hydroxychloroquine, azathioprine, or cyclophosphamide with MMF, they moved to target therapy because maybe of side effect like serious infection that may be attributed to the immunosuppressant. The new targeted therapy, they have recent insight into pathogenesis of autoimmune disease, lead to development of novel classic agents that targeted specifically the dysregulation of component immune system in SLE and lupus nephritis. The Ballista was the first targeted therapy especially developed for and approved for SLE and lupus nephritis. Some B-cell targeting agent approved for under investigation in SLE and lupus nephritis involved in variety of pathogenesis of pathways. So as we see that Ballista is targeted to the BLyS, which is B lymphocyte stimulator, and the infliximab to block the interferons for the new medications that used like etacept and telecept that work in April, the other stimulator and B cells. Rituximab is a CD20, which is B cell depleted, along with the obinutuzumab. As we know that the auto-reactive B cells are the central derivative for inflammation and SLE that can lead to organ damage when the BLyS conjugated to B cells and make it autoreactive and prolong the survival of B cells. Ballista is targeted autoreactive B cells function by blocking their survival without binding directly to B cells and causing complete depleting of immune cells. This can reduce the disease activity and reduce the organ damage progression. The Ballista can control the central drive of the underlying disease without broad effect on the immune system, without depleting the B cells, and that can impair the immune response to the patient and increase their infection. So as we know, with increasing BLyS serum level, more than 2 nanogram per milliliter, they predictive the SLE. With higher BLyS level, higher flare, which increase the inflammation, and this can be burdened over time. This is the selected Ballista phase 3 study, which was done on 865 patients. They have the SLE disease activity more than 6, and they have positive antibodies at their baseline. There is reduction in anti-double strand by using Ballista as early as week 4, and that was continued throughout 52 weeks. Again, with C3 and C4, they increase from their baseline as a good positive effect from Ballista. And this will give an early improvement in B cell and double strand of Ballista that was associated with fewer flare rate, as we shown here, and decreasing of anti-double strand that leads to decrease the number of flares throughout 52 weeks. So there's significant change was observed in 8 B cell subtypes throughout 8 weeks, and was associated with reduced the risk of a flare development from week 24 throughout week 76. So summary, this is the summary for the evidence for predictive of SLE management. Steroid sparing agent, they reduced the steroid use by 50% over 6 months, and the disease activity and 55 patient was reduced, and severe flare risk was reduced by 39% in 1 year. The joints improved outcome by 60%, and skin was 59%, and the kidney was improved by 53% of the patients. The patient on Ballista, they have less than half organ damage progression by 5 years compared to the patient on standard therapy alone. So the Ballista approved to be more than the 10 years experience real world in real world. Sorry. For patient with lupus nephritis, the steroid sparing was improved more, giving 51% more likely to reduce the steroid to less than 5 milligram per day. The protection of kidney risk of flare was reduced to 55% across class 3, 4, and 5 over 2 years compared to patient on standard therapy. The renal complete response improved by 74% in 2 years versus standard therapy, and the GFR was 63 less loose in GFR over time compared to the patient with standard therapy. And this is the prescribing information QR code. That's it. Thank you.
Thank you very much, Dr. Mana.